So good afternoon, everyone. I am Dr. Dhaman from Nepal. I am thankful to organizing committee for having me here. So the ankle impingement syndrome is not as uncommon as we think. But most of the cases, what happened that it's undiagnosed or often overlooked that cause the patient to suffer for a longer time before right diagnosis is made. I'm not sure about here, but in our context, the diagnosis is still in dilemma. And this is also supported by several literatures like these are the systemic review and meta-analysis, and they conclude that exact numbers on the incidences are still missing. I will start with a couple of cases. This is a 23-year-old male presented to us with pain right ankle since 4 years following the ankle sprain. His main complaint was when he tried to play football, he has pain. And he was about to start the career in football, in national football, and due to same reason, he is not able to do that. So initially he went to blood investigation to rule out inflammatory infective pathology. MRI done 5 times. The MRI reports were normal. First MRI shows ganglion cyst around the FSL. So initial surgeon thought that the problem is the ganglion cyst and he removed that ganglion cyst. But there's no improvement in the symptoms. Since last 6 months, before he came to me, he was on oral steroid and multiple times injection steroid given locally under CM guidance. But still symptom is persistent. When I examined him, the only finding was single illness test was positive, otherwise other findings were normal. This was the X-ray at that time. This is another case, 36-year female, pain right ankle since 8 years, following the ankle sprain, and since last 4 years, she had locking of ankle joint every time when she walks for 5 to 10 minutes. Again, treatment history is same, till steroid. Then when we examine her, the only finding was tenderness over the anteromedial ankle, and other findings were normal. This was the X-ray at that time. So we'll discuss this case later on. So the ankle impingement is the painful mechanical limitation of ankle ROM that is secondary to either osseous or soft tissue abnormality. In 1943, McMurray Morris was the first to describe footballer ankles for the anterior ankle impingement, whereas in 1940, Wallin et al. Was first to describe anterolateral impingement. These are the common area in anterior and posterior where we can anticipate the impingement. Now the broad spectrum of pathology with varying etiology, either it can be due to bony problem or due to soft tissue condition. There is no such classification for the treatment purpose, but it is described according to the anatomical area involved as anterior, posterior, and syndesmotic. In anterior impingement, the entrapment of the structures was along the anterior margin of the ankle joint when it terminally dorsiflex. For anterolateral, the soft tissue impingement is common, whereas for anterior and anteromedial is bony impingement. So it mainly is seen in the people who have repetitive dorsiflexion movement like football players and ballet dancer. When there is repetitive kicking with foot in full plantar flexion, that cause the repetitive capsular ligamentous traction and that lead to traction spur. That might be the reason for anterior impingement, and literature shows that 60% of soccer players have spurs. When there is recurrent ankle inversion injury, there is compression of tibio-talar ligament between the medial malleoli and the middle talar border, and that might be the cause for bony spur growth, and that cause anteromedial impingement. For anterolateral, there is entrapment of the fibrous tissue, synovitis, or ligaments due to the damage by lateral ligamentous complex, and that cause microtraumatic injury to tear by inversion sprain. In chronic instability, what happened that there is excessive anterior displacement of the talus, and that cause excessive contact of talar dome with distal fascicle of the AITFL, and that cause anterolateral impingement. So literature shows that 1/3 of patients with chronic ankle instability have ankle impingement. For posterior one, compression is in the anatomic region between the posterior tibia and the talus during the terminal plantar flexion, and main cause is the lateral posterior of the posterior talus. It can be seen in acute fracture, repeated microtrauma, mechanical irritation of the surrounding soft tissues. It can also be seen in ankle or subtalar osteoarthritis. Mainly younger one who is involved, active in sports activities were mainly involved and present with chronic ankle pain. For anterior impingement, pain is mainly aggravated by terminal dorsiflexion while doing the climbing stair, running up hills, ascending ladders, or squatting. In bony impingement, dorsiflexion will be limited, whereas if it is isolated soft tissue, only finding will be the popping and snapping sensation. For posterior one, pain is due to the Achilles tendon that is exaggerated by downhill running, descending stairs, high heeled shoe wear. We have to look for alignment, swelling, and tenderness. If there is tenderness in anterior and anterolateral side, that is more or less suggestive of anterior impingement. But if it is increased with dorsiflexion, that is more or less confirm the physical examination for the anterolateral impingement syndrome. Posterior one is difficult as structures are deep enough. But if there is posterior medial ankle tenderness with resisted plantar flexion of the first MTP joint, that is mainly suggestive of FHL pathology, whereas posterior lateral tenderness with forced plantar flexion suggestive of trigonal process involvement. We also have to look for peroneal tendon, ankle instability, and radiculopathy. These are the basic X-ray that we need: weight-bearing, epilateral, and Motis view. These are some of the ankle impingement view, like lateral dorsiflexion view to rule out anterior impingement, whereas plantar flexion view to rule out posterior impingement, and this is lazy lateral view. It's mainly recommended to see the good profile of posterior talus. MRI gives indirect evidence like bone edema, effusion, synovitis, and condyle injury. Sensitivity is up to 89%, whereas specificity is up to 100%. But there is paper by Liu et al., and they concluded that sensitivity is only up to 39%, whereas specificity is 50%. So we can't only rely on MRI findings. CT scan is needed if you are thinking of bony impingement. Can be managed by non-operative or by operative techniques. Initially, it is symptomatic management only by avoidance of activities, ice, and some time of immobilization. In chronic case, shoe modification can work. A steroid injection will work in selected cases. So trial of non-operative treatments should be attempted for at least 3 to 6 months before going for operative one. Operative one is indicated when the symptom is persistent and not responding to the non-operative management, and approach is again depend on the anatomical area involved. Main goal is to remove the offending pathologic lesion that contribute the symptoms. Either we can go for open or arthroscopy, but open one is come with significant complication rates. So Hawkins in 1998 was first to describe the arthroscopy approach for treatment of bony anterior ankle impingement. Nowadays, arthroscopy approach has become the gold standard for every ankle impingement cases. There are some cause of failure by arthroscopy treatment. It's not due to arthroscopy approach, but it's due to the inadequate dissection of tibia or talus, failure to completely debride the medial or lateral gutter, failure to realign the joint or mechanical axis, and if there is improper indication. This is the first case that I have described earlier. So footballer guy, pain while kicking. If you see in the lateral X-ray, it shows the long STDA process there. This is the full plantar flexion view. If you can see, there is very minimal space between the tibia and talus, and that might be the cause of impingement here. This is the MRI that again shows the long STDA process. This is the typical feature of MRI. This patient came earlier. In acute part, if you can see, there is edema and capsular thickening there. But in this case, as patient already have gone for multiple steroid injection, oral steroid, you might not get typical MRI findings every time. So it's easy for me because patient already have gone for everything they have tried. So we decide to surgically remove the STDA process. So we went for posterior approach to remove the STDA process. And this is the STDA process, FHL. We work lateral to the FHL. And this is after removal of the STDA process. If you compare the post-op with the pre-op, you can appreciate the gap between the tibia and talus. This is after a couple of months, patient sent me the video like this, and he is very happy that he has no pain. It's more than 1 year follow-up, and he won't have pain, and he is playing football comfortably. This second case, where the finding was only anteromedial tenderness and she had locking. As she had locking, we are anticipating some bony impingement here, so we send the patient for CT scan. And you can see there are osteophyte from the tibia here. In MRI, we can appreciate the osteophyte along with capsular thickening and soft. No, video is not playing. So this is debridement, and we can appreciate the opening of medial gutter as we compare to the first slide. Then we went for the osteophyte of the medial malleoli. Once we clear the medial gutter, this is the osteophyte, and this is how we remove the, again media is not playing, so we are removing the osteophyte there, and this is after removal of the osteophyte. And after that, patient is walking without pain or locking. Now she has more than 2 years follow-up and she won't have single episode of locking and pain there. So what we learned from both cases,
Thank you, Dr. Jha.
thank you, sir.